Hi, my name is Jeff Lee, and I'm Assistant Professor of Medicine at the University of California, San Francisco. On behalf of my co-authors, I'll be presenting the results of our study, which was recently published in Clinical Gastroenterology and Hepatology, titled Adjusting for Patient Demographics Has Minimal Effects on Rates of Adenoma Detection in a Large Community-Based Setting. Colonoscopy is the most widely used colorectal cancer screening test here in the United States. Colonoscopy can reduce the risk of colorectal cancer incidence and mortality through detection of early-stage tumors and removal of adenomatous polyps. Conversely, failure to detect adenomas during colonoscopy may increase the subsequent risk of colorectal cancer. Physician adenoma detection rate, or ADR, is defined as percentage of screening colonoscopies performed by a physician that detects at least one adenoma and has been recommended as a quality benchmark by multiple specialty societies. More recently, the ASG and ACG task force recommends ADRs of 20% or higher for female patients and 30% or higher for male patients as indicators of adequate colonoscopy quality. However, multiple studies, including one that we published last year, have reported that ADRs vary widely amongst gastroenterologists, and this variability predicted subsequent risk of colorectal cancer and mortality. Reliable estimates of ADRs are needed to inform colonoscopy quality standards, yet little is known about the contributions of patient demographics to variations in ADRs. Therefore, the aim of our study was to evaluate the impact of adjusting for differences in patient case mix on ADR variability in a large group of endoscopists in a community-based setting. The study was conducted among health plan members of Kaiser Permanente Northern California, an integrated healthcare system serving approximately 3.4 million people across 21 medical centers in Northern California. Using a retrospective cohort study design, we collected data from Kaiser Permanente Northern California members who were 50 years or older and received a colonoscopy between the years of 2006 and 2008 from a gastroenterologist. We evaluated ADRs for 102 gastroenterologists before and after adjustment. ADRs were adjusted for patient age, race, ethnicity, and family history of colorectal cancer using multi-level logistic regression with clustering on physician. The 102 gastroenterologists included in the study performed a total of 108,662 colonoscopies, of which 20,792 were screening exams. Adenomas were identified from the pathology database, and cancers were detected by using the Kaiser Permanente Northern California Cancer Registry. Here are the results of our study. For patients undergoing screening exams, 58% were female, 64% were non-Hispanic whites, 52% were 60 years or older, and 16% had a family history of colorectal cancer. As you see in Table 3 for screening exams, the ADR of the 102 gastroenterologists was 30.2% for male patients, 19.7% for female patients, and 24.1% overall. Of the 102 gastroenterologists, the unadjusted ADRs varied widely, about 8-fold in men, about 27-fold in females, and more than 7-fold for both sexes combined. The distribution of ADRs for screening exams is also shown in Figure 1. Adjusting for patient age, race, ethnicity, and family history of colorectal cancer decreased the variability from 8-fold to 3-fold for male patients, from 27-fold to 5-fold for female patients, and from 7-fold to 4-fold for all patients combined. Because adjusted ADRs cannot be compared directly with unadjusted ADRs or with rates recommended by gastroenterology societies, we evaluated the effect of case mix adjustment on changes in the rank order of physician ADRs. For this analysis, physicians were first ranked from 1 to 102 on the basis of their unadjusted ADRs. We then contrasted physician rank order after case mix adjustment. As seen in the table, the median change in order resulting from case mix adjustment was 2 ranks for male patients, 1 rank for female patients, and 2 ranks for male and female patients combined. When male and female patients were combined, case mix adjustment changed the order by 5 or more ranks for 8 physicians. The largest increase was 7 ranks, and the largest decrease was 8 ranks. Adjustment increased order by 5 or more ranks among 5 physicians whose patients were slightly younger. The mean age was 62.9 versus 63.9 years, and they had significantly higher proportions of patients who were in the 50 to 54 year age group and 50 to 59 year age group. Conversely, Adjustment decreased rank order among 3 physicians whose patients were slightly older. The mean age was 65.1 versus 63.9 years, and they had significantly higher proportions of patients who were in the 70 to 74 year age group, 14% versus 12%. In summary, the detailed current analysis demonstrates the adjustment for case mix among physicians reduced the overall variability in adenoma detection rates from 7-fold to 4-fold, but only modestly influenced the rank order with the median change of 2 ranks. This suggests that in a widely dispersed medical group with numerous medical centers and local variation in patient demographics, some of the variation in detection rates is related to differences between physicians and case mix. But these differences do not markedly influence the rank order of physicians by ADR. For those physicians whose rank order changed 5 or more ranks, differences in the age distributions of their patients appear to be the driving factor. The findings of our study raise the question of whether ADRs should routinely be adjusted for case mix. The need for adjustment will likely depend on the degree of variation between physicians and patient case mix and how rates are used as a performance metric. Adjusted rates would likely only be needed in settings where physicians had very different patient demographics relative to sex and age. In contrast, our study suggests that moderate variability in patient demographics is unlikely to substantially change the rank order of ADRs among physicians. Also, if ADRs are used for tracking colonoscopy quality improvement trends, unadjusted rates may suffice for measuring the relative changes in each physician's detection rates over time or between physicians. Thank you for your attention.